All right, Fred, you are ready to roll.
Great, thank you. Good morning, everybody. Thanks for joining us. This is a talk on the changing face of autism, new perspectives on outcome. I'm Fred Volkmar. I work both at the Yale Child Study Center, but also at the Department of Special Education and the Autism Center of Excellence at Southern Connecticut. And the owl and the bulldog come up because they're the two mascots of the two institutions. And here are my conflicts of interest, of which I would point out to you if you're interested in autism. This is a new book that has just come out, and I don't know if you can order it from Amazon yet, but I know you can order it from Wiley, and it's the second edition of a book written specifically for parents and teachers on autism, practical guide, and it's on wiley.com. So I want to talk about some very good news and also some less good news today in terms of outcome, give a little bit of an overview and talk about some of the various issues in interpreting the outcome studies and what they mean. And then I want to talk about development in several senses, both of individuals and the field, what the research tells us, and some of the challenges that adolescents and adults face, the gaps in knowledge, and also prospects for the future. And hopefully we'll have time at the end. Case reports of children that probably had autism were seen starting in the 1800s. Actually, if you go back, there's this lovely book, A History of Autism, called In a Different Key, that talks about this. From our point of view, the two major figures in this field, Lee O'Connor in 1943, who talked about early infantile autism, and Hans Asperger a year later, who talked about autistic personality disorder. Essentially, they're talking about when you put the two things together, a spectrum, a more narrowly defined view as per Connor and the broader defined view as per Asperger. And they're all talking about problems in social communication and unusual behavior. It was a long time, almost 40 years, before autism was officially recognized, and that then led to its own explosion of research. So let me say a little bit about the development of the field. The important advances in the 1970s that led to the recognition of autism. The first was the recognition of autism was brain-based. There were clearly high rates of epilepsy. It's also really the origins of the neurodiversity discussion and movement. Autism also became clearly strongly genetic. Family studies showed a very strong connection in identical over fraternal twins. The genetics are very complex and they cover a broader range than once we thought. And that's also consistent with the broader phenotype issue that we'll come back to. Also, it became apparent that structured education was better than unstructured psychotherapy. We're going to come back to talk about that. The evolution of the concept, there's a lot going on this slide. I won't dwell on it. You can come back and look at it later at your leisure if you want to download. But basically, there was an evolution in DSM-3 back and forth between broader and narrow. The first definition in 1980 was a very strictly infantile autism definition. They didn't deal with developmental change at all whatsoever. There was a funny category called residual infantile autism, which was not a very satisfactory category if you were a child, adolescent, or adult. And so more recently, we moved to autistic spectrum disorder, which is great. We're going to talk about some of the problems with DSM-5 in just a second. I should also point out that in addition to the categorical, there are a number of dimensional approaches, now over 40 or so. These are used for screening as well as for diagnosis. There's just a host of these out there, the CARS, the ADOS, the ADI, the Gilliam Autism Rating Scales, there's a RITFO scale, MCHAT, the SRS, and so forth. One of the questions for these dimensional approaches is where they come from, what their differing purposes are. Some are screening, some are diagnostic. There also are important and emerging issues of gender, ethnicity, and age. And there are particular issues in terms of picking up people with more cognitive ability, higher levels of cognitive ability, and also some cultural issues. Those have all emerged as important topics in the last few years. And if anybody has a chance, we can talk about some of those during the chat. It does have some relevance to adults who come to diagnosis late. So let me say a word about DSM-5 and autism. You'll get a very quick sense from the GIF at the top of the screen of what I think about it. There's no longer subtypes and subthresholds. Asperger's is gone. We went from over 2,200 ways to diagnose autism in DSM-4 to 12 ways in DSM-5. So you might think that the categories are going to be somewhat narrower, and indeed they are. For those of you who are really interested in this question and the disappearance of Asperger's, this book by Gary Greenberg is a good reference, the Book of Woe. One of the things that made for some trouble for the DSM-5 people, my colleague Jamie McPartland, Brian Ryko, and I reanalyzed data that had come from the DSM-4 field trial. We found a large number of cases and re-rated them using the new DSM-5 criteria and discovered that many cases who previously had a diagnosis of Asperger's or PDD-NOS would now lose their diagnosis. About 80% of them, essentially. Interestingly enough, of the high functioning people with autism, the people with autism who functioned above IQ 70, about 25% of them also lost their diagnosis. And this reflects in some ways the way the DSM-5 was done. It was really done using the data from the ADOS and the ADI, which are two really excellent instruments. But these are instruments that really were designed to have a very stringent approach to the diagnosis of autism for genetic studies. So guess what? You get a more stringent diagnostic concept. The current state of things, well, the good news is we have some good assessment instruments. We have better awareness. We have better services. There's increasing interest around the world. The bad news is our screeners do not work so well, especially for young children, unfortunately. And there's a big debate at the moment about whether screening is even worth it at 18 and 24 months. And that's a battle that's raging even as we speak. DSM-5 clearly does not work so well for the more cognitively able people. The solution, after not only our study, but another couple of studies appeared, the DSM-5 folks added a little one-line proviso to the DSM-5 system that said, well, if you already have a well-established diagnosis of Asperger's or PDD-NOS, you get to keep it. Well, so the problem is that leaves sort of Asperger's out there hanging. People that had it keep it. On the other hand, new people can't get it. So they're excluded from the whole package. So it makes for a very funny system. It's like I sometimes say, it's like running two trains on the same track without knowing the schedule for each. And it leaves the issues of the broader spectrum hanging, even though the change in name to autism spectrum disorder is clearly a good thing. In point of fact, the definition is more like the old Connors infantile autism. Just to mention the genetics, which have gotten very complicated. This is a slide from Emory looking at all the various genetic studies in autism. There's some very good resources for this if you want to take a look. There's clearly been a lot of work, not only in single, but also multiple genes involved in the conditions. Genetic testing is now finding between 10 and 20% of the time some gene or genes that might be involved. Again, this whole package of stuff is very consistent with the broader spectrum, which suggests that some other combinations of genes might lead to lesser degrees of autism spectrum disorder. But again, that's a whole complicated topic relative to the DSM. The other thing that's important to realize is there have been very important advances in terms of understanding how the brain works in autism. Autism has really emerged as the prototypical social brain disorder. And indeed, it's kind of taken its role in that whole body of work in the social neuroscience, studying how social information is processed in the brain. We know, for example, that these frontal parts of the brain are involved in things like theory of mind. This part of the brain, the STS, the superior temporal sulcus, looks at things like biological movement, whereas the fusiform gyrus is helping to make sense out of looking at faces. So there are a whole range of brain functions and structures that now are seen to be involved in autism, and we know more about that. When you talk about research progress, one of the places to start really is this book, which is now, 20 years old. Kathy Lord was the chairperson of this committee, and I was also on this committee. It was a group of 15 or so people who were organized to answer a question from the US Department of Education, which is, does early intervention make a difference? And we did a very thorough job of having hearings and holding reviews and looking at all the data. We looked at 10 programs. The requirement for these 10 programs was they had to have had at least one study in a peer-reviewed journal that showed that their program had some significant benefit. These programs, which really were quite wide-ranging, had many commonalities and some differences. The things that they had in common was that structured teaching was important, about 25 hours a week for preschool children, and that we needed much more work on treatment. Since this time, evidence-based work has really mushroomed. I'm going to show you a slide in a second that gives you a more recent reference, but we've seen the development of a number of model programs. These are behavioral programs like ABA, the LOVAS program, the more developmental programs like Sally Rogers, Early Start model, and the Connie Cassary, Jasper model. And there's some hybrid programs. The pivotal response is the best example of this, that it combines the developmental approaches, so it targets certain specific key developmental areas, but it uses behavioral techniques. And finally, there are eclectic approaches like Division Teach, and then also specific intervention tools within this broader package of the model programs. Certain ABA procedures, social skills, PECs, and so forth have been shown to be evidence-based. This is the work I was mentioning to you. It's available online for free. It's a very valuable volume if you want to go find it. It's on the Frank Porter Graham website. That's the University of North Carolina, Chapel Hill. There's been an explosion of research. If you type into Google, as I did earlier this week, you get about 246 million hits for autism. So what are you going to do with that? Even if you limit yourself to scientific peer-reviewed papers, not chapters and books, but papers, you have over 40,000. So we have a real problem here. And one of the good parts of this is that there's been greater stringency looking at evidence-based treatments. When that NRC report was done back in 2001, they only had one peer-reviewed study. They only had to have one to get in. These days, that would not nearly cut it. These days, you want multiple randomized controlled trials, you want meta-analyses, you want independent replication, verification. So that really it's gotten a lot more sophisticated. And again, we have some good things like the Cochrane and Campbell collaborative reviews that are taking on aspects of autism treatment. So for example, you can find reviews of social skills interventions in autism and how well they work. And the big but here is a big but, the research is really very uneven, especially limited for adults and for the treatment studies relative to adults. Whoops, sorry, much of what we know has to do with children. This is a slide that just shows you, this is from that report I just gave you, looking at treatment studies in relation to age. And you can see here the big explosion. Most of these studies are coming from preschool, school age. By the time you get to adults, a very small number of treatment studies overall. One of the other things that's been very good is that we've had models of autism, psychological theoretical models, things like theory of mind, central coherence, executive functioning, and active mind. All these approaches try to pull it together in some way. They all have their pros and cons, but one of the good things is that they often have now been taken to the next step of thinking through, well, what could we do based on these theories to make interventions? So there are, for example, books about working on teaching theory of mind skills. There's programs on dealing with executive function problems, programs on dealing with social skills. So what does all this mean for outcome? Well, we knew we have better and evidence-based interventions. We also have a range of those. We have some limitations in terms of the age, but we also know that the increased awareness of autism has led to better diagnosis and earlier diagnosis. And we think this has led on balance, mostly, and again, mostly, not always, to better outcomes. Also, clinical work and research have gotten more integrated together. So we're now seeing things like brain changes, for example, in response to treatment being used in treatment studies. What are some of the issues in terms of as we implement better interventions? Well, one thing we have to take note of and acknowledge is the important influence of Public Law 94-142 back in, I think it was 1975, that for the first time mandated schools. Any school that took a cent of federal money had to take any child that walked in the door. There was no more exclusion of kids. Before this time, children with disabilities, especially kids with autism, were excluded from schools and thus from education. As a result, some parents started at some schools, which still exist. Other programs really didn't exist. And so kids were put in institutions, which is where they stayed into adulthood, and all they learned is to live in institutions. So The good news is Public Law 94-142 was the sea change in that. I'm going to talk about outcome research in a second. There are many different studies of outcome. Pat Hallen in England is probably the big maven on, it's undoubtedly the big maven on this. And she's grouped studies in terms of 3 categories of outcome: good, which means you're independent; fair, which means you're semi-independent; and poor, not pair, sorry for the spell check, poor, which means you need 24/7 care. We'll talk a little bit about optimal outcome in a second, what it is and when you see it and what to do with it. And some of the challenges for prediction. And again, as with all the treatment studies, there's very little out there in terms of intervention for adults. And by the time you move out of younger adulthood into middle age and older adulthood, there's almost nothing. Whoops. And here we are, outcome studies. This is synthesizing Pat Hallen's report in the Handbook of Autism. I think this is from 2005. And these are the first outcome studies, 56 to 74, the first 5 outcome studies of autism. And you can see here the good outcome means you're independent. About 5% of people became independent. About 2/3 were in residential 24/7 institutional care settings. But then look, I take a 15-year hiatus here, and then I look at the next set of studies. And the reason I stop here is this is when Public Law 94-142 kicks in, and we give it 15 years to work. And I stop here because we stop when DSM-4 is coming out, and that might impact it in terms of things like Asperger's and might inflate the good news numbers. But look at what happens to these good numbers. We're now talking 25%. And probably a similar, maybe slightly lower fair percent, we're getting close to 50% of people who are having a good outcome. And again, you can see the bad outcome, it varies, it's spotty, but it's much lower than before. So there's clearly something going on, and there's good reason to think this is continuing to be the case. Sorry, on a hair trigger. There we go. Let me say one word in case you're wondering, where's the place to live in the US if you want to have the best outcome? And the place is Utah. There's a published study by Farley et al. And if you look at that study, this is the place to go. And again, the mean IQ is 89. Half the people were employed or independent. Half the people were independent. 66% were employed. About 1 in 5 were in long-term relationships. One of the interesting things about this study, of course, is for its setting. As setting is Utah. And Utah is a very interesting state. There's obviously a certain amount of homogeneity in terms of religion, but there's also some interesting things about Utah in terms of the population, many small towns, degree of acceptance of people. So there are many good things about Utah, but if anybody asks you where to live, if you've got autism and you want to have the best outcome, move to Utah. Optimal outcome. Let me say a word about this. This is a concept Debbie Fine and her colleagues up at UConn came up with. This is referring to a group of cases they found where the children had adults technically, quote unquote, outgrown their autism. And what does she mean by that? Well, they no longer met strict criteria for autism. And so she did a study looking at those individuals, a comparison group of people who still had high functioning autism, and then also a typically developing group. They were matched on age, sex, and nonverbal IQ. And she found actually only minimal differences, but some in terms of the optimal outcome group had milder symptoms earlier on, and they had done much better clearly because they were now functioning quite independently and look very good. A whole series of subsequent studies have shown some interesting subtle differences in that optimal outcome group around pragmatic language and other questions. Let me say a word about the economics of autism. The costs can be high. There was a study in 2006 that said that we were spending about $3.2 million per person over the course of a lifetime of care. This would have been about $35 billion annually. Martin Knapp in England at 2009 thought they were spending about 25 billion pounds a year for the care of adults with autism. So clearly increasing functional outcome has important economic as well as social policy and ethical implications. Well, why has outcome changed? Well, we think early diagnosis and intervention does lead to better outcome using various metrics. We can look at associated rates of intellectual deficiency, mental retardation, how many people talk. There's some very straightforward metrics, all of which are moving in a positive direction. There also have been some changes in practice, but this is probably only a small contribution. In fact, the current system is probably tightening up things, so things may look a little worse for a while. But we're getting more and better evidence-based supports. Now, let me point out here that not every child gets dramatically better, and that's a problem. We see some children at 2 and 3 and 4, and parents will rightly ask, as you can imagine, after they spend a long time getting an assessment, well, how's he going to do? And I have to say, I can't tell you. And the reason I can't tell you is there's so much variation in children. And you will see some kids at 3 and 4 who will just take off like a rocket. I have a set of videos, which I'm not going to show here because I don't have the permission to do it, but I show in some of my classes because I got permission for that. I've got a 2-year-old spinning around my office doing what his mom calls airplanes. I've got the same child at 15 doing stand-up comedy on national television. And that's a child who was perfectly mute at 2.5. He got involved after our assessment, and his mom was really a great person about getting him intervention. And around 4, he just took off, literally like a rocket. And he's doing very, very, very well. Now, he still has issues. And that's back to the optimal outcome. These people still have subtle or not so subtle issues, even though they quote unquote technically lose their diagnosis. I should also point out here that there's some issues in terms of matching children to treatments. Some schools will have a TEACH program. Well, maybe the kid really needs an ABA program, or the school has an ABA program. Well, maybe the kid's higher functioning and could use a more developmental approach. So that's one of the issues. And as you already know, there's a dearth of studies on older individuals. So it's an interesting and complicated issue, making sense out of all the outcome work. Let me also point out here, as Pat Hallen has noted to us, what's a good outcome? Well, most of us who are neurotypical think of a good outcome as being independent, self-sufficient, marrying, hold down a job, having 2.5 children and a dog. In point of fact, when you talk to people with ASD who are adults, who are less impaired, they say, well, I like a quiet place. I'd like an employment that's not very stressful. I'd like good internet. I mean, they have a list of hierarchy of things that, most of us, in terms of thinking of what it means to good life, internet's not the top 5 of our list. If you're a person with autism, it actually is the top 5 of your list. So it's important to think about some of those things as we take a step back and ask ourselves, what for us is a good outcome and what might be a good outcome for the person with ASD. Vocational planning is increasingly important. We're going to talk about one of the problems, people with autism who are doing better and better in school, and then they tend to fall off a cliff once they get out of high school or college. We have more and more people out there who would like to get jobs. It used to be there was a greater range of jobs in the sense that there was sheltered employment, supported employment, now independent employment. Increasingly, we're moving away from sheltered employment to supported employment, even for more impaired individuals, and that's obviously with some supports. By its very nature, it's supported. But we're having more and more people look for independent employment. This has some complications. People with ASD have some strengths as well as some weaknesses. They have some important interests as well as some challenges. Those of us who've dealt with many adults with autism have many examples. I have one man I know, the first person I ever met who went to college who had ASD. I knew him for a couple of years and I worked with him, and we struggled to find him a job. This is the guy who got a couple of master's degrees. He discovered he could do college. He loved college, kept getting master's degrees, but then he had to stop. He had to get a job. I got him a job keeping the catalog at the library at the medical school, the card catalog library at the medical school. Some of you who are my age will remember the card catalog, which was a set of big wooden boxes that had these index cards, one for the book title, one for the book author, and one for the book subject. This was before computers and the internet and everything else. And you could go through and you could look to see where the books were and use the Dewey Decimal System, blah, blah, blah. This guy was the best person ever. Everybody said, he is the best person ever to keep the card catalog. He got fired within a month. The reason he got fired is one problemo. He did not want anyone to use the card catalog. People would come through and they put little yellow stickies in the card catalog and he would yell at them. And I don't mean raise his voice, I mean wake the dead yell. And he couldn't stop himself. And again, that's the funny kind of thing when you get into this. It seemed like a great thing, and it was a great thing in many ways, except for the interaction with people aspect, which turned out to be a real problem. And this was early days. These days, I would have anticipated that problem, but not then. Some of the challenges, obviously social communication problems, difficulties with organizations. Rehab services get to be a little more expensive within adults. Most people don't know about the departments of voc rehab in all the various states. There's been much interest in supported employment. There are about 16 papers from 2000 to 2010 related to work. There's a few more now, but it's still a pretty sparse literature. One of the problems is sometimes people will get unskilled, poorly paid, and very, very stressful jobs. And then you make them feel even worse, even though they are employed, because they're so stressed out all the time. Even in a normal adult, people with normal IQ, as we know, there's a whole range of people being employed and unemployed. Pat Hallen and Moss in 2012 found that only about a third of people outside of high school were either in school or in work. She found that one of the problems was the use of services when they were used by adults who were higher functioning. All the services were mostly designed for people with intellectual disability. There were a lot of issues with stress and fit for the papers. And again, that recurring theme of only a small number of papers were available, and that sadly still is true. So jumping off the cliff, well, adolescence obviously is a challenge, as is the transition to adulthood. Medical care issues, behavioral and psychiatric care issues become important. People often transition out to adult mental health care systems where people may have very little knowledge of adults with ASD. Well, we need supports in a number of areas that people aren't traditionally trained to think about. Things like adaptive skills, vocational and organizational skills, social skills, communications, living supports, bullying, sexuality. There are a number of resources out there, but you have to have somebody who knows these resources and can help people either connect with them or can help people learn to use them. I'll give you a quick example. I had a Yale student I worked with for about a year and a half, 2 years, who as a freshman, every 2 weeks, he was sending his mom back in, wherever the heck it was, a big box via UPS of his dirty clothes, and she would wash them and send them back to him. And the reason is he could not go to the laundry. He could not go downstairs and use the laundry. And the reason for that is even at 2 in the morning, there'd be people down there. They'd be chatting each other up. They'd be having a brewski. They'd be smoking a joint. They'd be doing something. And he just couldn't take it. He hadn't bargained for that. And so he sent the stuff home to his mom. It took us a long time to help him. He was also somebody, interestingly enough, who sadly was being bullied by his professor. And I couldn't believe it. And it was in his favorite subject. And so I got his permission and went and sat in on the class. And by gosh, he was being bullied by the professor because he did not know how to ask the question. He couldn't not have his hand up. And so people were making fun of him, including the professor. That's a whole interesting topic for discussion. Maybe we can come back to, because I pointed out to the professor and we worked out a solution. But it can be a challenge because people get to college and they don't know how to behave. They don't know classroom etiquette. And they don't know that you only ask 1 or 2 questions. After that, everybody, including the professor, sees you as somewhat weird. As kids transition out of high school, the main important thing for parents to know is what's the successor IDEA of Public Law 94-142 no longer applies. You're now into the world of the Americans with Disabilities Act. Whole different law, whole different standard. And it creates many new challenges, especially when you have that drop off in terms of the level of intensity of services. That's one of the reasons why it's so important in high school to include the students in the planning process, and also to help them in terms of their vocational skills, looking at internships and actual experiences in high school. Thinking about having an afternoon off a week where they can go to the vet and work in the animal clinic, or go to the library and work in the library, or go to Dunkin' Donuts, or going to a local industry, or going to whatever. But having places for them to have actual work experience is really important. Living arrangements, there's now a number of possibilities ranging from group homes to supported living to independent living. We have more and more people who are living independently. We also have more people in relationships. probably 10 to 20% now. Some of these are marrying and some are having children. I emphasize there's no systematic information on the children born of these unions. Given the genetics of autism, you would assume there's probably a higher genetic risk. And my limited experience anecdotally is that that's probably true, but there's nothing that I could actually show you to cite that as a fact. In point of fact, though, more and more people are marrying. Again, limited information, but more and more people are pursuing relationships, which is great. College. Well, college is more and more of an option for students. We have new challenges for supports in college. College is not a right in the United States. It's not like public schools. The Americans with Disabilities Act applies. It helps if you self-identify, and you have to self-identify the student, not the parent. The student has to come into the disabilities office and say, I have autism, here's my documentation. And then you get things like extra time on tests, you might have a tutor and other things. One of the challenges is that the college disabilities programs, they know ADHD, they don't know autism quite so well. And so thinking about some of the non-academic challenges, the academic skills, yeah, but also the adaptive skills. How do you get along with a roommate? How do you learn about taking care of yourself? Looking also at the various alternatives, there are now about 75 at last count transitional programs available. We have some good ones here in Connecticut. We have Chapel Haven. I should note I'm on the board of Chapel Haven. It's a great program. It's right here in New Haven. It's a transitional program. We have Thames Academy up at Mills College. Many of the colleges in Connecticut will offer, or at least say they offer, some special supports for people with ASD. I say they offer because once you get into it, sometimes it's quite minimal. Again, different laws apply in college. Students must identify. Parents cannot identify it for themselves. Parents have to realize college staff won't talk to them. I had a student not so long ago who was significantly depressed, and I got his permission. He came and told me that he had done really well. He'd stopped his meds. He was doing so well. And all of a sudden he was feeling depressed. And after I got permission, I talked to his mom. And the first question out of her mouth is, well, is nobody making him take his meds? And the answer is, yes, you're correct. Nobody's making him take his meds. He's in college. And so that's one of the issues. And so the supports, some things like extra time are easy to give. Other things, social skills supports, peer counseling, well, that can be done, but you have to think about how you're going to implement it. You need supports in terms of social relationships, organizational and adaptive skills. The demands in college are very, very different than in high school. You might have a class. I mean, I teach a class over the summer where there's short papers every single time we meet, but those are one pagers. And then there's a term paper. That's it. Well, for some kids, that's, all of a sudden they have to study at the end. They have to pull together a paper. It has to be a well-done paper. So the expectations in college, it's very different than in high school, where people are using quizzes and reading all that stuff to help the kid keep up. That drops out in college. The expectation is you're learning on your own. Well, again, one of the bits of good news, colleges came out of monasteries. If you visit the old places in Europe, the colleges, University of Bologna, Cambridge, Oxford, and walk around the buildings, these were monastic. These were monasteries. They have order and structure, rules and routine. That's a plus as far as our kids are concerned. There's food, there's books, there's entertainment, and you can easily minimize social interaction, although not totally. As I mentioned, classroom etiquette and important independent study skills are critical. Some fields find this much more easily to accommodate. Math, some of the basic sciences, stats, other kinds of things are full of minimally interactive people in my experience. Other fields, psychology, English, even history for that matter, you need to have more in terms of social interaction skills going on. So it's going to vary somewhat depending on your field as well as the college. Mental health supports, we clearly need new models of intervention. I'm going to talk to you about some of the changes with CBT in just a second. We need a longer term vision for things and probably more of a life coaching model. If we have time at the end, I'll give you an example of a student I work with. But you can do things where you're more proactive and interactive with the student. You give homework, you can do role play. You can have collaborative care things going on. Now, there are some limitations in terms of insurance reimbursement, which is pretty minimal for all mental health things, and for this, even worse. Counseling, again, there are some out there that have been used as model programs and techniques. There are some very good approaches to things like, for example, teaching social skills, the Liz Lagerson Peers program. It's important when you work with people to be flexible. It's not your usual kind of psychotherapy or counseling. You have to be a little more proactive. You have to know the special issues relative to autism. And you also have to be sure that the person's motivated. And again, if we get to my case, I'll give you an example of that and some new resources on CBT. So there are many other challenges. Again, I'll just mention these. And so there's some good ones in terms of resources. Social skills, obviously very important, different ways and approaches to teaching. I mentioned the Peers program from UCLA, which goes into adulthood. The social skills gap is tremendously important. Studies of the efficacy of social skills show us that there's a moderate effect size, about 0.4. If you exclude the weakest studies, it goes up to 1.0, which is strong. But our studies of eye tracking show that the deficit, using a statistic called Cohen's D, which looks at the strength of the effect. The eye tracking studies show that the eye tracking difference in terms of looking at eyes and getting social information, that's 3.8. So it's like we're shooting a water gun at a raging tiger, essentially. So that it's important to realize, we do what we can, but we got a lot to deal with. Adolescence creates a lot of issues around sexuality. There are more and more supports out there. There's a very good book on decoding dating by John Miller, a man on the spectrum himself, who's a high school English teacher, kids with special needs, and he breaks down dating so that you can teach dating skills. One of the things that's important is to realize that these skills can be taught. For most of us, we learn things like dating, a lot of things about peer interaction, social interaction with girls, boys, et cetera, from our peers. We talk to our peers. That's largely absent for our population of kids on the spectrum. Also, we learn from our parents. That's somewhat there, but again, that learning is often minimal by the time you get to high school. Siblings are another source of information. That's also somewhat variable in terms of our population. So you have to learn about what you can talk to and what you can't talk to and who. And that becomes really very important. Legal issues arise in many contexts. The more impaired cognitively, there's guardianship issues, estate planning issues. There's a 7-fold risk for some involvement in the criminal justice system. This has to do with things like poor judgment, social isolation, and so on. We're about to post, I think in the next month, a whole series of talks for, unfortunately, a fee on legal issues in autism, specifically for lawyers, to try to help cope with this problem. There's some reports with people with Asperger's been increased risk of violence, but there's not great systematic data to show this. What we do know is that about 40% of people in the US with autism Asperger's are bullied. That's double the general population rate of 20% of school-age kids. And if you have autism and something else, if you have autism and Asperger's and anxious, that rate goes about 75% of kids are bullied. This is a major, major problem. It's important to think about planning for the more cognitively impaired. This includes guardianship or conservatorship. With the Britney Spears business, you know a lot about this on the public media. A conservatorship or guardianship has a whole set of different rules that can apply. This has to go through a court and a judge. And it also has to do with managing things. It's also important to realize that parents have money they want to leave to a child, especially if the child is in an institutional setting, to leave it through the context of a special needs trust for the child, because otherwise the state will just take that money and zoop it back to reimburse themselves for the child's care. Here's a quick case example. Take a second and tell me, what do you think this page of equations is about? Take a second to guess. This is a young man with Asperger's who's very mathematically inclined and interested. He lives in the world of math. He's asking the question, will I ever have a girlfriend? So number one, you realize if he's asking the question that way, we know the answer, which is he's not going to have a girlfriend. And the other thing that's interesting is if you look at the bottom here, he comes to that same conclusion. And this is somebody who's tried to commit suicide several times. And one of the problems, sadly, we know as kids get older, and the double-edged sword, increased social awareness, motivation to change, also increased depression as you're aware of being different, and increased anxiety as you put yourself more out there. You're also more likely to experience rejection. Interestingly enough, psychotherapy for many years had a bad rep in ASD, but it's making a comeback around CBT, cognitive behavior therapy. Modified CBT is now increasingly used for adolescents and adults and even for school-age kids. It respects the style of learning. It has many good things going for it. You use homework, you involve the client in terms of setting the goals and what you're working on. You have to make some modifications for ASD. You have to expect it's not going to be something you can do 10 sessions and call it a wrap. It's something that's probably going to be ongoing. There's a new book by Susan White and Tony Atwood that's just coming out on CBT. I got a chance to read it while it was in press, to do a blurb for the back cover, and it's a really great book, and I recommend it very highly for those of you who work with this population. But again, it's something to really think about because it can be very effective. So here's my case example. I'm almost done, believe it or not. I had a young man whose parents came to me, and this is when I was a department chairman at Yale, so I had very limited actual patient time, but they came and they said they really wanted me to work with their teenager who wanted a girlfriend. And I said, does he want the girlfriend or do you want him to have the girlfriend? Oh, no, he wants the girlfriend. And then I met with the kid, and the kid was really motivated to get a girlfriend, and he really wanted to work and have a relationship, and he wanted to have more friends. I mean, he had a good set of goals for himself. So we started to work together. And the reason I show these two pictures is he got very attached to me in his own somewhat odd way. He would come in twice a week, pull out a little notebook at the end of the sessions when he was downstairs waiting for his mom, and he would write down rules he had learned from the session. 157, Volkmer says, don't pick your nose, girls don't like it. And a couple of weeks into the session, I said to him, Joe, which is not his real name, Joe, I want you to do something today. This is while we're playing chess, which we always did. And he looked up at me, which was rare. And he said, what? What's that? And I said, I want you to pretend I'm a girl. And he looks at me with wide eyes. He says, Dr. Volkmer, I can't do that. For goodness sakes, you're an old man. You got white hair. You got a mustache. And why should I do that? And I said, Joe, if you can pretend I'm a girl, I can tell you what the girl is thinking. And he looked at me. He was stunned. And he said, you can really do that? And I said, yes, I can do that. And so anyway, we worked together for quite a while. He had multiple dates. He had double dates. He started a chess club in high school, which was a very smart move on his part and my part. And he did really well. And I show you these slides because I once had to cancel a February session with him because I had to go down to DC for a meeting. And he knew I was going to DC, and he knew there was a blizzard. Everybody knows DC just falls apart whenever there's snow. And so I called multiple times, and the Acela going down stopped several times. It was like Murder on the Orient Express. So the conductor could check the tracks. Did you get there? It's impossible. So the next morning I'm getting onto the red line. And well, it turns out this kid had two special interests, one of which was subway lines around the world. So he knew about LA, he knew about Moscow, he knew about Paris, he knew about Washington, he knew about London. Anyway, I got a text from my patient who had my number. And just as I'm stuffing myself into the red line, I get a text and open it up for my patient as the door is closing. It says, Dr. Volkmer, for God's sake, don't take the red line. And he was absolutely right. The doors stopped. We moved for about 3 seconds and then stopped for about 30 minutes because there was a disabled train. Well, I mention this only because he was really connected and he was worried about me. And it speaks to the fact that he could make a relationship. He could use it very profitably to work. And he's now doing very well in a college in Boston and about to graduate. Very quickly, can you guess this man's special interest? The man here who the police are taking away? This is a very famous man, Darius McCollum. I don't know him personally, obviously. I wouldn't mention his name otherwise. This is from the New York Times. He's interested in subways. Buses also, but he likes subways. He likes to take subways. The driver of the subway pops out for a fast smoke. Darius pops in and drives the subway off. The first time the judge was amused. The third time the judge said, sing, sing, prison. So this was not a happy story. Sometimes you can use special interests. Sometimes they're a real problem. Again, we need a lot in terms of policy. Had Mrs. Clinton won the election, one of the things she was going to do was do a study of the needs of adults with autism. That was my big suggestion to her. not just count them, but find out what their needs were. But we don't need to know more about treatment, what works, looking at especially intervention work, service, developing new models of care. We need to look at how autism works across America. There are a whole set of issues that we really need to get into, and thinking about public policy. We know with the internet now, there's so many hits. It's impossible for parents and for people with ASD to find good web resources. I would mention to you, there's a couple of good talks. If you go to YouTube, there's a Yale Autism series, and our Southern website also has a nice talk series that you can come to and watch for free. So a very quick story to end. I have an autism class at Yale I've done for about 30 students. I have about 25 kids per class. One of the interesting things a few years ago, I had a student join the class who identified to me as having ASD. He did not identify to Yale. We had a man, Ben Carey from the New York Times, who came and talked to the class about reporting on autism. And afterwards, I took Ben out to dinner at Maury's, the local establishment, and took a couple of the students from the class, including the student who had told me privately, but who had not talked to the class about this, that he had ASD. And Ben and the student and my wife, who was coming with us to dinner, went upstairs to my office, and I joined them. And Ben's mouth was wide open. And I said to my wife in the walk over to Maury's, what's going on? And she said, your student told Ben he had autism. And that's great. And that's now happened multiple times in my class. We have at Southern 40 students who have self-identified as having ASD. The last I heard, there were about 5 at Yale. So that's great. It's a testament to the progress in the field. But again, the problem is we need to think about supporting them as they get through college. So let me thank everybody for their interest. I got a bulldog, and I hope I haven't put you to sleep. I want to save some time for questions. And I will put up for you, I'm just going to briefly show them now, but they'll be on the PDF file. I've got several sets of references here. And let me end with a thank you. And here's our website. If you'd like to register for future events, or if you would like to support our work, you're more than welcome to do that. Let me leave this up there and stop and see if we have time for some questions. Oh, I should put that slide back up. Let me see if I can put it back up. I'll stop right there, see if we can open up for questions.
Thanks, Fred.
Okay.
We had a couple comments. We haven't had any questions. If anybody has any questions, please put them in the chat, and we can try and address them. So one of the comments we had early on was that from one person named Sarah, that it's hard to ask for accommodations as well when on the spectrum. Any suggestions, maybe?
Well, actually, legally, and again, I realize that there's the law and there's what's hard. You can ask, you can tell employers, look, I have some, you can also, you don't even have to say autism. You can say, I have learning disability. I have a learning problem. And I will sometimes talk with students about how to package this for employers. And you can say, I have a learning problem. I have some organizational issues, but I need help in the following ways, or I need supports in the following ways. You don't necessarily have to have the A-word talk. And I guess that's the first thing I would say. And then also think about what's the fit between you and the possible either job or class or topic. Again, if you look at some of the classes, you can think about ways. There are some classes that are notorious for causing trouble. Lab classes where you're working with partners. Classes where there's, again, group work. English is a notoriously difficult one for many people with ASD. And there, again, if you talk to the professor, and often then talk to the learning disability support people, or the job situation, if you talk to them and say you have a special need, and you don't necessarily have to get into the whole history of diagnosis and who diagnosed you when and where and what, but just to say that you have a learning difference and tell them that you have some special needs, they really need to accommodate you, and there can be a legal consequence to them if they don't.
Thank you. Another comment that we got was dealing with the trying to get better outcomes, and that professionals need better training, that they need specific training with working with people with ASD, and they need to be aware of difficulties that adults with autism face so that they can provide better early interventions and school age interventions. I don't know if you want to comment on that.
Yes is the answer. I mean, there's no, absolutely. And we need to make more of an effort to do that. And that's why I think we need to work. I mean, I need to work, for example, with people in internal medicine, family practice, not just pediatrics. I need for my special ed hat on to work with people not only in high school, but also in college, and also looking at vocational supports and programs. One of the things we just did at Southern was put in a special program, and you can see our video if you go to our website, for people with autism who drive, to have a practice police traffic stop. So they could come in, they could be stopped by the police in a controlled setting where the police are not going to give them a ticket, but they're just going to show them how does it go. And Connecticut, we have a special program for people with ASD who drive called the Blue Envelope, which they can keep in their car, that identifies to the police officer that this is a person with autism, tone it down a notch or two. And so there are things that you can do. The sad thing is it's really hard to get out there. Most of the research right now is on infants and very young children. A lot of the interventions in school are focused on school age kids. We really need a big push, and I hope maybe the Biden administration will take it on to think about supports for adolescents and adults.
Fred, our next question, do you have recommendation for books for young emerging adults with ASD?
There's going to be a whole set of readings on the reference list that I would take a look at. There are some good books. I'm trying to think of one that comes to mind. There's a couple of good also video resources. There's of course I'm going to block on them. There's James Stansfield. That's not as good. There's Coulter, Coulter. There's Coulter videos. Go to that website. There's some good videos. I don't know how much they're for young adults. I know they're for high school students. Excuse me. And I'll find some books and put them up on our reference list.
Great. Another question. Do you think the laws, insurance funding need to be updated again to require licensure for a particular population, i.e. ASD, rather than just BCBA, LBA?
You know, the trouble, even right now, you know, we've moved to reimburse ABA. So a lot of people have moved into ABA treatment. They get, how shall I put this? I have to be diplomatic. They get some kind of certification, but they don't have a lot of training. And so you'll get people where, as far as I can tell, it's glorified babysitting. And the state is paying for it. It's the same state pass-through that pays for Medicaid. So it's not very well reimbursed. We have some fantastic ABA therapists and supports in this state, but they're not going to take the state insurance because it pays so minimally. And so that's kind of one of the questions of reimbursing. This is also true for all the mental health stuff. You know, the sad tragedy is people who are poor get reasonable mental health coverage through Medicaid. People who are wealthy pay for it privately. The middle class have to go through their insurance, where there's not much, because most psychiatrists, psychologists who do high quality work don't want the hassle of dealing with all the insurance company paperwork with minimal reimbursement and horrible intrusion in terms of the process. And how many more sessions you got? So that's a real dilemma, and I can understand both sides of it. On the other hand, I think we need to hold the insurance companies' feet to the flames and make them really ante up if they say they're going to cover. And that's one of the things I think also that's worth thinking about, a new model, maybe having nurse practitioners who learn more about disabilities in general, who can be more conversant with all kinds of the range of interventions and supports for children, adolescents, and adults. That might be a very good program to develop at a place like Yale Nursing School.
Couple more questions. This should be a quick one. What is the percentage of LGBTQ adults on the autism spectrum in the US?
Sorry, that's a good question. I think we don't know the answer. Okay. And I had a slide which I skipped over in terms of just the interest in time. We're more and more aware of several issues with adolescents and adults. Many are coming out and saying that they identify as LGBTQ other. And that's important, obviously, to support them. It's increasingly a phenomenon. I don't think we have good data. I know it's increasing. I know more and more people are doing it. We're also having more and more people talking about gender identification. People who are born male who are identifying as female as they get older, and vice versa. There's also very small literature, interestingly enough, on people in adolescence and adulthood who I think are largely treating their anxiety and depression with substances. that are illicit. So mostly alcohol, but sometimes other things. I've had 1 or 2 people get involved with heroin. So that substance abuse is also an interesting issue. As you see people get older, again, my sense is people are self-medicating, but there's not great data on this, but there's a handful of studies. People probably know, but if you don't, there's a great resource that's perfectly free to you to use if you're a US citizen or even if you're not, called PubMed. It's the US Library of Medicine down in DC, and you go to PubMed and you type in what you want: autism, gay, autism, gender identity, and all of a sudden you'll see papers. And often you'll not only see the abstract, you can go to the actual paper itself. So it's a very good resource to use.
The last question, Fred, I'm not sure if this is a general question or one more specific to you, but they're asking, can you do a remote evaluation based on report videos?
You know, I think one of the troubles is it's really hard without knowing the person. Obviously, these days with COVID, things have been very cockafluey. And I'm actually moving into retirement mode myself, so I'm less involved in the day-to-day, week-to-week assessment of people. But I think one of the problems is some folks will do more remote things. I think, given COVID, I think one of the, at least my experience is it's very different than actually being in the room with the person with ASD and their families. And so again, I think people do their best with what they got, but it's not ideal.
One more. Can you
Okay.
explain more about transition programs for college or include a list of recommendation programs in your resources?
Oh, sure. There's a couple, let's see. And again, just in terms of time, I didn't get all the nitty gritty. There's a couple of good programs to know about, and there's one published paper, sadly. 75 programs, there's one published paper. Susan White, the University of Alabama, has a program down at the University of Alabama supporting students, and she has published data on it. The division Teach people are collecting data. They have a very nice program, which we're hoping to maybe implement at Southern, which is a first-year support program for students with ASD. And the division Teach people, I don't know that they published on it yet, but that's a very good program. Chapel Haven here, and I think the Chapel Haven people would also be able to put you in touch with other programs. Mills College, I mentioned, there are, as I say, about 75 of these programs. And I'm sure if you send us an email at the center, we could help you track down more of them. There are a number of them around the country. As I say, sadly, there's only so far one published paper. These programs tend to be expensive. Sometimes you can get the school to pay for 3 years after the kid turns 18. So sometimes the school will pay for 3 years of a place like Mills or Chapel Haven or some other program to give that extra 3 years of support to get the student really launched. I wish I could say that there was more empirical data. As far as I'm aware, it's still only Sue White's program at the University of Alabama.
So that was the last question. I'm just going to put up our flyer. Ooh, that's not the flyer. So sorry. That was my email. I'm just putting up the flyer. We do have another program coming up December 3rd, the Global Perspective on Autism and its Treatments Across the Geographical and Cultural Context. And then we have we actually have 3 programs that are scheduled for January, February, March. They're just not on this flyer as of yet. But that is all available at the link down below, the bit.ly Science of Autism link, which I also put in the chat. Please feel free to register for those. They are free, and you'll receive the Zoom link once registered. Thank you all so much for coming. Have a wonderful weekend and happy Thanksgiving to all of those in the US.